Hi, and welcome back to week 2. Remember, we are now in the week of treatment and planning of ocular disorders. This week, we were supposed to have read chapter 4, 18, 19, and 20 from the primary care textbook, as well as chapter 5, eye guidelines from your CASH textbook, and chapter 64, 65, 66, 67, and 69 from your Coiler textbook, which really goes into the nursing procedures and how to perform them. So let's get started. Again, I'm Jessica Stoneland Franchi, the professor for this semester, and I'm really excited and honored to be part of your journey. So let's get through this. I'm going to really try to go through a nice intro and overview of your readings from this module. There are 2 more PowerPoints that we will go through after this recording that I'll briefly go through. This particular lecture actually overviews both of those 2 PowerPoints following this. I will still do a voiceover in them, but very brief. I don't feel it's necessary to read the slides to you. I just want to make sure to point out to you things that are really important, especially pertaining to both practice and questions that you should know, or information that you should know in regards to your boards. So let's get started. So let's just review week 1. Week 1 module included introduction to family theories, harm reduction, health promotion, disease prevention, and immunizations. We did get a lot into how to look at health and disease prevention. We talked a lot about primary prevention, where we are trying to prevent disease or eliminate risk factors for an illness. We talked about secondary prevention, in which we talked about early detection of a disease to minimize bodily damage. And we talked about tertiary prevention, which is the last intervention, and that is to reduce the impact of disease or injury, including rehabilitation, support groups, or any sort of supportive equipment that you would use. Let's see, next. So in terms of health, we talked about the components of health here in this diagram right here. It really goes into the nurse practitioner's view on health and how we really try to encompass all the different components of health, including both physical, psychological, social, cultural, and spiritual. We also got into talking about how the community affects health. We talked about risk factors in health promotion, including non-modifiable versus modifiable factors. We talked about influences on health promotion, including health literacy. Where is your patient at in terms of their understanding of their condition, their acceptance of it, and their education level. We talked about government initiatives in terms of their influence on health promotion. I really wanted to reiterate and reinforce the 3 major initiatives that impact health promotion in the USA, which includes the NPS, the National Prevention Strategy, which came from the Affordable Care Act, which was passed in 2010. We have the Healthy People 2020, which is objectives and measures for the government to use to guide our healthcare. And it's based on evidence-based practice, as are all of the initiatives. And then, of course, one of the most important ones that I would really encourage you to look into and really review, especially in terms of preparing for your boards, are based around the U.S. Preventative Services Task Force, the USPSTF. And that task force is composed of experts who make recommendations for clinical prevention strategies, specifically based around evidence-based practice. We did get into the U.S. preventative health screening recommendations, which I'll show you in the next slide. And I do want to go over that a little bit more, just because those are really important in terms of screening, using that as a screening tool, and when to screen and what to screen for depending on your patient's age. And that's really important that you know what the USPSTF recommendations are, because it's also influenced on insurance and coverage in terms of clinical screening tests or other recommendations you make. We also got into practical epidemiology, which is the importance of monitoring trends in healthcare and disease that may affect your patient's health. So understanding important terms in terms of epidemiology includes morbidity versus mortality, prevalence versus incidence, sporadic, epidemic, endemic, and pandemic. Those are all really important terminology, epidemiologic terms that you should know. If you really wanted to review them, there's a really good table in your textbook on page 36 that reviews the terms and their definitions. You know, I just want to really reinforce health promotions is one of the most powerful tools available today to prevent disease and disability. We always should use health promotion strategies at every level of prevention, including primary, secondary, and tertiary levels. Each level of prevention is very important, but the ultimate goal is primary prevention because it has the most impact, the most significant impact on disease. And engaging in primary prevention strategies like health promotion, you know, they create wonderful opportunities for patients and healthcare providers to work together as a team with the common goal of wellness and disease prevention. You know, sometimes when you're not really sure which health promotion strategies to use, you could always look to the Healthy People 2020 and the USPSTF to provide you with guidelines to initiate secondary prevention strategies. And I'm going to show you on the next slide. I would definitely advise you to go to the USPSTF website and download their most recent guidelines, which are really helpful in terms of, you know, using them to track where your patient falls in whatever category. Here again is just a review in terms of the health promotion in the community and within the individual. And just having all of these factors in terms of promoting health can really lead to really big success for your patient. This on the right-hand side, this little algorithm right here is based around the health promotion model. And really, it's about changing your patient's behaviors. So first you have to recognize their perception of where they're at in their health and what their perception of what's going on is and their definition of health. And then you can use this to help define modifying factors for your patient to decide, you know, how well they can participate within their own health promoting behaviors. Okay, next. Okay, so here is the USPS screening recommendations. This is right on their website. You can go to the website and it's literally a graph, and you'll see at the top, it gives you the age, and then based on their age and their risk factors, this will kind of guide you as to when they would be appropriate to screen and, you know, when the insurance company would actually cover them based on the evidence-based practice of these particular guidelines. So things you want to definitely keep in mind in terms of, you know, what guidelines are out there. There's a lot. There's guidelines around using aspirin to prevent cardiovascular disease, and that's usually within the ages of 50 to 59 years old. You know, based on their risk factor, initiating a low dose aspirin for primary prevention is something that the USPSTF recommends. They have recommendations about breast cancer and cervical cancer and when to start screening. So for instance, breast cancer, we're screening them starting at age 50, and they repeat that every 2 years until age 74. After age 75, there is no point to do any further screening because there's insufficient evidence for that routine mammograms actually do any kind of prevention at that point. Now, keep in mind that the screenings are not for every single patient. It's a broad, guidelines. Keep in mind that if there's any known genetic mutations, specifically like in breast cancer, or familial breast cancer, or a history of chest radiation at a young age, women should be started to be screened in their 40s for breast cancer. So there are different factors that you need to look at in terms of screening. And this is very important because when we start getting into genetics, which we are getting into if you're in my patho class, you'll understand that these recommendations really, really are important, especially if there's any kind of genetic history in the families. There's also guidelines in terms of cervical cancer, colorectal cancer, lipid disorders, lung cancer, prostate cancer. Prostate cancer is a big one. Usually between the age of 55 to 69 years old is when it's important to start undergoing prostate cancer screening through a PSA and a prostate exam. Okay, potential harms versus the benefits are definitely something you need to talk about with your patient in terms of prostate cancer. So just keep that in mind. ovarian cancer, skin cancer screening, um, and anything with oral cancer or testicular cancer. Those are not really recommended by the USPSTF unless there is a history within the family, a genetic history. So again, those are your screening recommendations from the USPSTF. Okay. So next, the next big thing we talked about was immunizations. And again, another website to definitely you want to check out and have really saved in your files besides the USPSTF are the CDC. So the cdc.gov is where you're going to get all your recommendations in terms of immunizations. We talked about immunity, active versus passive versus herd community immunity, and we talked about the different vaccines that are important to get depending on your age, depending on where you're at in your career. Obviously, for healthcare professionals, there's different vaccines that we are required to get. And as you know, as a nurse, that you're getting your titers evaluated every so often to make sure your immunity is there. We talked about formulations of vaccines, inactivated versus live vaccines. We talked about contraindications and safety issues, like in terms of reactions, and making sure you report it to the health department if you have any concern that a vaccine possibly could have caused an allergic reaction to a patient. What else? We definitely got into things about vaccines that you need to be conscious of in terms of allergic reactions, in terms of catch-up schedules, and in terms of asking to make sure when if they have any allergies, when their last menstrual period was, if there's any concern or possibility of pregnancy. Okay, those are things you need to make sure you find out. Keep in mind certain things about vaccinations. Without treatment, in terms of tuberculosis, 1 in 10 people with latent TB infection will develop tuberculosis. Another thing I want you to keep in mind is antibodies against influenza take about 2 weeks to develop after vaccination. The flu vaccine can be offered even into January or later because sometimes the flu season can last until May. Keep in mind, for patients aged 65 years or older, the higher dose vaccines are more effective. And you want to try to remind patients to get the flu vaccine by the end of October. Vaccinating too early, like in July or August, may lead to reduced protection against the influenza later in the season, particularly among older adults. So again, in terms of prescribing vaccines, you want to just go ahead and get your immunization schedule from the CDC. Okay, so clinical pearls regarding immunizations. Things to consider in practice when immunizing your patients. These are questions you always want to ask, okay? Number 1, which vaccination should you expect the patient to have already had? Those are things you're going to want to already have in your back pocket in terms of just kind of getting an idea of what they should have already had. And you can just go ahead and look at the CDC schedule to kind of try to pinpoint what they should have already had based on their age. Remember too, you want to really make sure you know where the patient is from. If they are from out of the country or they're immigrants, you want to keep that in mind because their standards of vaccines are very different than ours. What do you need to know when prescribing? So does the patient have any allergies? Are they allergic to eggs or baker's yeast? Remember, with Hep B vaccines, if they have a history of baker's yeast allergy, they are not to get it. You want to know their pregnancy status, the last menstrual period. You want to know their HIV status and their CD4 count. Okay, that'll depend. That'll be a consideration in terms of vaccinations. You want to make sure you have any records of their childhood vaccines. So try to get in touch with their primary care physician so you actually have an updated chart with all of their vaccines. You want to know if they got chickenpox as a child. Do they need the varicella vaccine at this point? Have they had a flu shot? Did they get their COVID vaccinations? And if they haven't, why? You want to make sure you educate your patients. You're going to educate your patients about vaccinations, the importance of how they prevent long-term issues. And you also want to make sure you educate them before you give them the vaccine on the vaccine, what they can expect, what an allergic reaction would look like, and when they need to call for any kind of emergency services. You will obviously want to ask them if they've had any previous reaction or allergy to vaccines, because that also will dictate what vaccines you will or will not give. And you want to make sure, like I said before, is to provide education and consent to the patient prior to vaccinating. Remember, you are documenting carefully that you did provide consent, that they did get their education that they needed to get for that particular vaccine, whether it's to the patient or the patient's parent, caregiver, if it's if you're dealing with a minor. Okay, good. Okay, so this week in week 2, we're focusing on the art and diagnosis of treatment, as well as common eye complaints, conjunctival pathology, visual disturbances, and impaired vision. We're going to get into eye guidelines and the different testing techniques that we can use within primary care practice. I want you to keep in mind, for most NPs, ophthalmology is a specialty. So when you get the patient, it's usually going to be most likely in a pretty emergent situation. Most people don't come in to see an NP in a primary care office or an urgent care place unless there's something newly, suddenly wrong. If anybody, most people will go to the eye doctor and schedule eye doctor's appointments for basic eye exams and follow-ups. But if you have a patient coming in with eye complaints, the most important thing as a nurse practitioner to know immediately is what are the emergency signs and symptoms that you need to be conscious of that need to be addressed immediately to prevent further damage to the eye, as well as something as severe as loss of the vision, which could be very serious and can happen very quickly when it comes to eye issues. So just be very conscientious about knowing what is an emergency and what needs to be handled immediately. And to be honest with you, the biggest things I remember seeing on the boards in terms of eye ophthalmology or ocular disorders was diabetic retinopathy and an emergent situation with eyes. So just keep that in mind. Okay, so first let's get into the art and diagnosis of treatment. That was in chapter 4. And basically it talks about the unique role of the nurse practitioner in clinical judgment, clinical diagnosing, and just the circle of how it all comes together. Remember, you're starting as a novice, you're a new NP. You're either in the novice or beginner role. And, as your specialty takes on, continues on and you get more experience, things will change. But in the meantime, we really want to kind of give you some tools to use, especially as you begin as a novice and a beginner, to give you some ideas of how to look at the patient and how to start asking questions and where to get information from. Okay. The advanced practice registered nurse, we provide unique services in any practice that we're in. Our care is based on current research. As we all know, we're very evidence-based practice, as all medical stuff is. We look, as nurse practitioner, we tend to look at the patient as a whole instead of just, a piece. Each little thing is a piece. We look at the full person. And we do more than just diagnose and treat. We really try to come off with caring and authentic presence, and we like to try to link the patient's experience in their lives with their health, their diagnosis, their choices, and their outcomes. So here in this, patient-centered care, this is looking at the patient as a whole, and all the different factors that come into play when you're actually really focusing on patient-centered care. So some of the things to start supporting your clinical judgment, the big thing I always say is you don't know what you don't know, right? So the tools that we are going to educate you on throughout this course are really going to help to support your clinical judgment. And remember, these tools are evidence-based practice tools. They're not things we just made up. So the whole medical world is using these, and based on these tools to help you come up with your clinical judgment and decisions. You can use this also in terms of your documentation to make sure that you can always have a source to refer back to help guide whatever it is that you put in place for your patient. So for example, here are 3 really important tools to use just in any assessment. And And here they go. So you have your SOAP note examples. I'm sure you've used this before, where it's the acronym SOAP is for subjective, objective, assessment, and plan. So here you're looking at the subjective information, which is statements about relevant patient behavior or status. For example, the patient's mother stated her teacher said she can understand her more. Okay, great. Then we have our objective data. And that's what we're writing in our notes as well. And this is what's measurable, quantifiable, and observable. So for example, the patient produced in the initial position of words with 70% accuracy given verbal visual cues for tongue placement. Okay, so this is for like a speech therapist. And then we have A for assessment, which is interpreting the meaning of S and O. So for example, production of N increased from 60% accuracy during the last session to 70% accuracy during today's session, giving visual cues for tongue placement. Okay, good. So it's showing that what you've put into place so far is actually helping the patient progress. And then P for plan. What is your anticipated frequency and duration, course of treatment for the next session, recommendations, and any changes? For example, the patient is approaching goal status for N in the initial position of words and continues to demonstrate progress with N in the final position of words. Next week, in the medial position of words will be introduced. So they have where they're at, where they're going, and what the plan is. Okay, so that's a SOAP note. That's how you can break down your assessment notes when you're documenting. I'm sure you'll be using this when you're entering your information into Typhon, when you're explaining some of your clinical situations. Here we have in figure 2, the genogram. This is really important for you to learn and understand because you are going to use this in order to catch any genetic issues that your patient may be experiencing. Based on any symptoms your patient may be experiencing, if you can create a genogram, this can kind of help guide you as to what may or may not be going on with your patient in terms of differential diagnoses. So if you find out through doing remember a genogram is done for 3 generations. So, and you'll use that to help just guide your patient to figure out what their family has, what's going on in their family. And this is a form that you can continually update with every visit. Sometimes patients don't remember what happened with their great-great-grandparents and they have to find out from other family members and get back to you. But it's important to try to keep this up to date and keep it, in the patient's chart and glance at it every time that patient comes in, just to make sure you're not missing something in terms of any kind of symptoms they're presenting with that may actually be part of their history, their family history. And, again, if you're in patho right now, we're going to get more into the genetics and genetic disorders and how to actually fill out a genogram. And I just want to make sure genograms, the most important thing is, that male, female symbols and the death symbol, like if somebody passed on, I think it's a black box filled in. Okay, and then you have the OLD carts, another acronym just to guide you in terms of assessing symptoms. So OLD cart is very common. You probably remember that from when you were doing your RN, where we look at onset, location, duration, characteristics, aggravating factors, relieving factors, treatments, and severity. A lot of the time we would use OLD carts to really quantify and assess pain. Okay, so don't be afraid to use these tools and use them all the time. And you'll find that after a while of using them, it becomes natural, and that's just how you end up documenting, and it really guides your practice to make sure it's thorough and evidence-based. Okay, so now we're going to get into the common eye complaints. And we will actually go back a little more into treatment planning in the next PowerPoint that I have. Again, it's a shorter PowerPoint, but it'll kind of get a little more focused in terms of the treatment planning, which will go kind of reflect on Chapter 4, the Art of Diagnosis and Treatment. But I wanted to just do an overview of the Chapter 18 through 20 in terms of eye problems. One of the biggest things we want to make sure is that you're just very conscientious about like the major eye things, the emergency symptoms to report, and the pathology of how this all works, and the tests that you will use to screen people and diagnose people and treat people. All right, so some of the most common eye complaints are dry eye syndrome, eye pain, excessive tearing, and red eye. So Dry eye syndrome is a multifactorial disease of tears in the ocular surface, and it occurs when the quantity and quality of tears fails to keep the surface of the eye lubricated, as opposed to excessive tearing, which is also known as epiphora, and that's an overflow of tears from one or both eyes and can occur continuously or intermittently. Eye pain, you need to make sure that you differentiate whether the pain is coming from the eye itself or from surrounding structures. Keep in mind the most common cause of eye pain is usually trauma, okay? And then red eye. Red eye is a non-uniform redness of the conjunctiva from hyperemia. Some other common eye complaints are visual disturbances and impaired vision, like floaters or flashing lights or photopsia. And that's a sensation of sparks or flashes of light. And it could also be caused by vitreal detachment. Okay. So I wanted to just give you a review question that you might see. Something like this would be on the boards. So here we have a 40-year-old male who is building a house, and he presents with a 2-day history of foreign body sensation and excessive tearing of the right eye. What type of exam is recommended initially? So A, cardiac exam, B, visual exam, C, neurologic exam, or D, cerebellar exam. So this seems like it would be very easy. Most everybody I'm sure has picked visual exam, but keep in mind, neurologic exam wouldn't be off the beaten path in terms of answering this if there was any change in this man's mental status. So just keep that in mind. Okay, so the answer is visual exam. Right, okay. So any patient who is complaining of new onset of eye symptoms should have a visual exam first, right? Again, we're talking about your eyes. They're a very, very delicate organ. And if you miss something, this patient could really have some extreme damage or possibly loss of vision. So you really want to do a very thorough, quick exam just to make sure there's not an emergency situation that needs to be addressed immediately versus something that can be referred out to an ophthalmologist. So when we do our visual exam for this particular patient, here's the things we're going to be looking at. We can check his distance vision by using the Snellen chart. We can check his near vision by asking him to read a paragraph or a book or a newspaper. And you also want to include an inspection of the eye, of the surface of the eye. Just look to see if there's anything in there, right? I can't tell you how many nurses I've had who've come to me to tell me something is going on, but they forget the basic thing of just looking. What do you see? Tell me what you see, right? You want to look at the pupillary reflex and the red reflex. And you also want to do a fluorescent exam to look for a corneal abrasion, which appears as pulling of the eye, which appears as pulling of the dye that is visualized using a blue light in a darkened room. So just to get a little more clear about these exams, let me show you your exam tools. So first things first, you're doing an inspection of the eye. You need to know your eye anatomy. So look at your iris, your pupil. Is it dilated? Is it not dilated? Are they both eyes dilated at the same time or not? You want to make sure there's nothing in the eye, or has there been any scratches or anything near the eye? Look all around it. Look at your eyebrow. Look if there's puffiness, swelling, redness, tearing, any kind of cruddiness in terms of like if it's bacterial conjunctivitis. Those are things you're really looking at. You're using the Snellen chart. You're using the fluorescent exam to see if there's any foreign body in there. And we're going to look at videos to really pinpoint how to use these particular tools during your exam. So these would be abnormal eye exams. So remember, we're looking at the perla. Pupils are equal, round, and reactive to light and accommodation. If they're not of equal size or they're not round, this is a problem. Here's a normal reflex, no reaction required in terms of your red reflex. Red reflex is absent in one of the eyes. They need to be seen immediately. And here, again, red reflex is abnormal. Again, this is an emergency. And they need to be referred immediately. Okay. Some other things I wanted to get into is just some differentiating red eyes. So there's different types of conjunctivitis, and you need to know the difference between the three. Super important in terms of diagnosis and treatment. All right, and it can be a little confusing when they first present. So you want to look for key things. So viral conjunctivitis is caused by a virus like a common cold. This type of pink eye is extremely contagious, but it usually clears up on its own within several days without medical treatment. All right. You do want to make sure the patient is washing their hands and they stay away from other children. Usually it's kids that have this. You have your allergic conjunctivitis, which is basically an allergy. They're having an allergic response to something, whether it's pollen, dust, animals, could be seasonal, or it could just be from being around somebody's cat. That'll resolve on its own once the allergic thing is removed from the patient's eyes or around them. Bacterial conjunctivitis. This is the one we have to really watch and treat. It can cause serious damage if it's left untreated. And usually with this one, you see redness and dryness and mucopurulent discharge. So this is where they get like crusty, greenish looking kind of crustaceans in the corners of their eyes. Okay. So that's conjunctivitis. Okay, so common causes of impaired vision. What are the eye issues that cause impaired vision? So we have a couple of major ones. Cataracts, glaucoma, diabetic retinopathy. Again, diabetic retinopathy was one of the things that is definitely probably going to be on your boards. So be very conscientious about making sure you pay attention to that and looking at pictures so you really can visually understand what exactly it looks like. Keep in mind on your board, sometimes the questions are actually pictures of a particular disease. For instance, when I had the question about diabetic retinopathy, it was literally a picture of the eye and it asked me what I was looking at. And I knew it was diabetic retinopathy based on, well, I'll show you the picture and I'll show you exactly how I knew it was. The other ones are macular degeneration and then refractory errors. I like this chart right here because it really gives you a classification as to like which ones are like the most prevalent. Cataracts are 45%, and your diabetic retinopathy are only 6%, believe it or not. Refractive errors are about 25%. And then you have your age-related macular degeneration at about 8%. So diabetic retinopathy and age-related macular degeneration kind of are like classified in the same amount. Okay, so here's just some more review. I like these, I am very visual, so I find that these pictures kind of put things in context and just kind of summarize things for me more easily. But again, common eye diseases, refractory diabetic neuropathy, uveitis, cataracts, glaucoma, macular degeneration, amblyopia, and conjunctivitis. Here are some causes of eye pain. Again, this is a really helpful little diagram in terms of differential diagnoses. Is it coming from the eye or is it actually a headache? You know, these are things you need to keep in mind. Okay, so here is some actual visuals of these common causes of impaired vision. So here is the diagram of the diabetic neuropathy that I really wanted to point out to you. For instance, on the boards, this is exactly the picture I got, that diabetic retina. This is your normal retina. This is your diabetic retina. Look at the difference, okay? Your vessels are all blurry. You have hemorrhages in there. See these hemorrhages? You have abnormal growths of blood cells. You can have an aneurysm in there, and you have something very important for you to remember, cotton wool spots. That is a terminology you really want to make sure you are aware of. Those little spots right there are very, very indicative of diabetic retinopathy. So if you see a diagram such as this with these little white spots, they're called cotton wool spots, you know immediately that's diabetic retinopathy. Next, we have cataracts. So here's your normal eye versus your eye with a cataract. Then you have your glaucoma, which I'm sure we've all seen patients with glaucoma. Glaucoma is a progressive damage to your optic nerve resulting in optic nerve atrophy and blindness. It's most typically associated with elevated intraocular pressure. In terms of the cataracts, That keep in mind, there's 3 different subtypes: nuclear, cortical, and posterior. And the incidence increases with age. As you get older, you're higher risk for getting cataracts. And in terms of diabetic retinopathy, keep in mind there's 3 stages: background, pre-proliferative, and proliferative. Okay, next is macular degeneration. Okay, this is huge. Macular degeneration is huge. It is the leading cause of blindness in patients over the age of 60. There's 2 types, there's dry and there's wet. Dry macular degeneration is slow progressive atrophy and degeneration of the retina, versus wet is age related, and it causes new blood vessels to develop under the retina and the macula, causing a sudden distortion or loss of central vision. So look down at this bottom box. It shows you here the stages of macular degeneration. Remember, at the age of 60. So at the age of 60, you want to start screening any visual disturbances in your patients. And if they do say it, you know exactly where to begin in terms of screening them with your eye exams, your Snellen chart. And then, of course, if you do find any deficits, especially with this sort of visual issues, you want to refer them immediately to an ophthalmologist, especially if there's any history in their family of that. Okay, so here's some just basic, this is to review your refractory errors in your visual disturbances. So I wanted to just point out there's a couple of different ones: myopia, hyperopia, and astigmatism. So basically, your normal vision, the light focuses on the retina, no problem, right? With hyperopia, light focuses behind the retina because the eyeball is too short or the cornea has too little curvature. And then hyperopia can be corrected with eyeglasses or contacts. So basically, those refractory errors are pretty common. I mean, most people present with the chief complaint of change in vision, especially as you get older, about 40, 45. That's when most people start having a change in their vision, and they need corrective lenses and vision correction procedures. Okay, eye emergencies. Here are most of the corneal issues that you'll see in the emergency department. We have corneal abrasions. Again, this is where you're looking at, they did the fluorescent uptake and they could see it with the dye. This is where the abrasion is. So how do you treat it? You give them some NSAIDs, oral and or ophthalmic drops. You're going to do topical antibiotics if they have contact lenses, right? You want to make sure they follow up within 24 to 48 hours with the ophthalmologist. Here we have a corneal ulcer. That, again, you want follow up within 12 to 24 hours, okay? And you need to make sure you get on the phone and make that appointment for your patient to ensure that that is in place. You want to start them on Cipro or ofloxacin ophthalmic drops, 1 drop every hour. Then they have the herpes keratoconjunctivitis, okay? That is very serious. It can lead to blindness. So you want them to follow up within 24 to 48 hours, and you want to start them on oral acyclovir, as well as a topical trifluridine, and that's 1 drop 9 times a day. So hopefully they have a caregiver in the house that can help them with putting those drops in. And you want to educate family members on hand washing and how to put the drops in appropriately if caregivers are going to be administering them. Remember, drops are not just as simple as just dropping them in the eye, no big deal. Like you want to show the caregivers or the patient the appropriate technique to make sure they're getting the full dose of the medication. Corneal laceration. So if it's a small one, you want to do some analgesia, some topical antibiotics. If it's large but partial, you want to be evaluated in the OR for possible closure, or if it's full thickness, you want to treat it as a globe rupture. That is a serious emergency. That patient will need to be in the emergency room until they are seen by an ophthalmologist or a specialist. Okay, so I wanted to go into the different testing that you had in your nursing procedures book. I'm sure you read about them, and that's great, but seeing the video and actually how to perform them is very important, because you may have to do some of this testing while you're in practice. So I want to make sure that you see a good video tutorial on how to do it, because the likelihood is You won't probably have the opportunity in clinicals to do any of these exams. So it's really important that you have some exposure in terms of just seeing how they're done. The first thing we're going to look at is an audiogram. It's usually used to do to for the detection of hearing problems or loss in most age groups older than 6 months age, 6 months of age. It's not effective with children younger than 4 months. Okay, so here we go. This is audiometry testing.
Hi, this is Tom from ZeroToFinals.com. In this video, I'm going to be going through audiometry. And you can find written notes on this topic at ZeroToFinals.com/audiometry or in the ear, nose and throat section of the Zero to Finals surgery book. So let's jump straight in. Audiometry involves objectively testing a patient's hearing by playing a variety of tones and volumes. Air conduction is tested by using headphones. And bone conduction is tested using a device called an oscillator that delivers sounds directly to the bones of the skull. Audiometry results are recorded on an audiogram. Audiograms can help identify and differentiate between conductive and sensory neural hearing loss, and we're going to talk in more detail about how this is done. Let's talk about audiograms. Audiograms are charts that document the volume at which patients can hear different tones. The tone is measured as frequency in hertz, which is plotted on the x-axis from low to high pitched. The volume is measured in decibels, which is plotted on the y-axis from loud at the bottom to quiet at the top. The lower down the chart, the higher the decibels and the louder the volume. The higher up the y-axis, the more sensitive the patient's hearing is. Hearing is tested to establish the quietest volume at which a patient can hear each frequency. This level is plotted on the chart. The louder the sound required for the patient to hear, the worse their hearing is, and the lower on the chart they will plot. For example, 1,000 hertz sound will be played at various volumes until the patient can just about hear the sound. If this tone is heard at 15 decibels, a mark is made on the chart where 1,000 hertz meets 15 decibels. If this sound can only be heard at 80 decibels, a mark is made where 1,000 hertz meets 80 decibels. Hearing is tested in both ears separately. Both air and bone conduction are tested independently. The following symbols are used to mark each of these separate measurements. X is used to mark the left-sided air conduction. A square-shaped closed bracket is used to mark left-sided bone conduction. An O is used to mark right-sided air conduction. And a square-shaped open bracket symbol is used to mark right-sided bone conduction. When a patient has normal hearing, all readings will be between 0 and 20 decibels at the top of the chart. In patients with sensory neural hearing loss, both the air and bone conduction readings will be more than 20 decibels, plotted below the 20 decibel line on the chart. This may affect only one side more than the other, or both sides equally. In patients with conductive hearing loss, bone conduction readings will be normal, between 0 and 20 decibels. However, air conduction readings will be greater than 20 decibels, plotted below the 20 decibel line on the chart. In conductive hearing loss, sound can travel through the bone, but is not conducted through air due to pathology along the route into the ear. Both air and bone conduction readings will be more than 20 decibels in patients with mixed hearing loss. However, there will be a difference of more than 15 decibels between the two, with bone conduction better than air conduction, plotted slightly higher on the chart. Thank you for watching this video. If you liked the video, left a comment or subscribe to the channel.
Okay, so just as a reminder, the reason for an audiometry evaluation or testing is to evaluate and determine if there are hearing problems or loss, and to prevent delayed speech and language development, because the two go hand in hand. Now, the likelihood is you will not be performing an audiometry testing. You will refer them to an audiologist. But it's important for you to know what this test is for and when you would, what indications you would need to use it for. So besides just evaluation of hearing loss, it can be a routine screening for infants and children, especially if there's any delay in speech. They do it for routine adult well care screening sometimes, especially if you have a patient who works in a noisy work setting. Like I said, if there's speech and language development delays in infants and children, if there's any poor academic progress in school-age children, if an adult starts to have any kind of deterioration in their interpersonal skills in home or work environments, as well as like any unexplained behavior changes, especially in the geriatric individual, those are indications the patient may not be hearing 100%, and they may not know, what's going on, so they start to deteriorate. These are all indications something's going on with their hearing. We need to check it out. Also, complaints of tinnitus, ringing in the ears, is definitely a reason to do an audiology exam. When I worked with the veterans, one of the biggest testing things we did for a lot of the veterans was an audiology exam, because of the fact that many of them had ringing in their ears from concussions or from loud explosions during their service time, or being, bullets going by their ear. Just anything loud like that can lead to hearing deficits. And just keep in mind, in terms of audiometry testing, contraindications to not do this sort of testing would be if there's any cerumen obstruction, like if there's a lot of wax stuck in there, you can't do this testing. Otitis externa, or if the patient's younger than 6 months old. Okay, next we're going to talk about tympanometry. Now, again, this is probably not something you're really going to be doing in primary care, but you need to understand what the assessment is for, why it's used, and how to interpret the results, so that if you do refer your patient out and your audiologist sends you back any particular results, whether it's from an audiometry exam or if it's from tympanometry exams, like, you want to know how to be able to read the results and understand, what the results were. Now, tympanometry is an objective assessment tool for the mobility of tympanic membrane, pressure within the middle ear, and the volume of the external canal. This tool is used to measure resolution of otitis media and serous otitis media, determine the presence of eustachian tube dysfunction problems, and screen for causes of developmental delays. Again, we're assessing the mobility of the tympanic membrane and pressure in the middle ear and the eustachian tube dysfunction. They would use this testing also for evaluating any hearing loss, ear pain, mobility of the tympanic membrane, to detect if there's any perforation. If audiometry is not possible, then they'll use this instead. And they want to make sure that there's an effectiveness of the pressure equalization of the eustachian tubes. A lot of the times, this is a particular testing they do for any kind of developmental delays in infants and children. Again, it's contraindicated in anybody who's younger than 4 months old or who has any kind of wax obstruction. All right, and let's watch on how to perform a tympanometry exam.
The purpose of this video is to give the observer a demonstration of how to conduct tympanometry. Tympanometry is a fast, non-invasive means of objectively assessing a client's middle ear system. Tympanometry can also assist in monitoring chronic middle ear fluid, to confirm tympanic membrane perforations, and to monitor eustachian tube function. Tympanometry is thus conducted as part of a test battery to supplement the findings of otoscopy and pure tone audiometry. Automatic tympanometers are commonly used in clinical practice. Tympanometry can be performed on clients of all ages. The clinician must select a 1 kHz probe tone for infants 4 months old and under, and a 226 Hz probe tone for adults. Clinicians should conduct tympanometry on themselves at the start of every day to ensure that your equipment is working properly. If the results are not similar to your expected tympanometry values, use a different tympanometer that does. Ensure that your equipment has been recently calibrated and undergoes repairs if faulty. There are several contraindications for tympanometry. It should not be carried out if the client has had recent ear surgery. Ordinarily, you should not test these clients within 6 months of surgery, or you should follow the recommendations of their otologist. Also, tympanometry should not be performed if the client has visible blood or discharge in their outer ear, if there is pain upon contact with the probe, or if the client has otitis externa. Testing procedure is as follows. The clinician has previously washed their hands, introduced themselves, and obtained consent to conduct testing from the client. They select a clean tympanometry tip of an appropriate size for the client in order to establish a good seal. Explain to the client that this is a quick test that assesses their middle ear health. Inform them that during the test you will need to remain still and to not speak. You may hear some sounds and feel a change in pressure. In order to straighten the ear canal, pull the client's ear up and backwards in adults and downwards and backwards in children. Establish a seal by placing the tympanometry tip into the ear canal. The test will automatically commence once a seal has been obtained, and this is usually indicated by a green light appearing on the tympanometer. If a yellow light or a red light is displayed on the tympanometer, this usually means that you haven't obtained a proper seal or that the tip is occluded. You may need to use a larger tip, use some Oragel, straighten the ear canal more, or maneuver the probe a little deeper into the ear canal. Once you've obtained a tympanogram, record and classify your results. Repeat the tympanogram if the client swallows, talks, coughs, or laughs during the procedure, or if you do not obtain a normal result, known as a type A tympanogram, in the first instance. Once you've completed tympanometry, remove the tip from the tympanometer, clean it using an alcohol wipe, and leave it to soak in ethanol before it's reused. If the tip has any traces of blood or discharge, throw the tip away immediately. You'll obtain 3 recordings from a tympanogram: the ear canal volume in centimeters cubed, the static compliance in millihos, and the pressure at which we obtain the maximal compliance in decapascals. These results can be used to classify the tympanogram into 3 broad categories, A, B, and C. A type A tympanogram suggests that the client's middle ear system is functioning normally. They are unlikely to have a conductive component to their hearing loss. A type AS tympanogram indicates reduced middle ear mobility, whereas a type AD indicates increased middle ear mobility. A type BL tympanogram suggests middle ear effusion, while a type BH suggests a perforation in the tympanic membrane or patent grommets. A type C tympanogram indicates that there is negative air pressure in the middle ear. This can be consistent with several things, including sinus or allergy congestion, the end stages of a cold or ear infection, or a blockage or dysfunction of the eustachian tube. To summarize tympanometry, it's an objective means of assessing a client's middle ear system, and it's regularly used as part of an audiologist's test battery. Check that your equipment is working well and ensure that there's no contraindications to carrying out tympanometry. Remember to repeat tympanometry if you do not obtain a type A in the first instance, and record and classify your results.
Okay, good. So we understand tympanometry. Next, we're going to look at visual function evaluation. So here, this video, I like this video because it gives you a basic visual eye exam, and then it talks about the different things that you're going to need to know so you can do a full assessment.
Hi, my name's Ash. I'm one of the final year medical students. Could I just check your name and date of birth, please?
Yeah, my name's Grace Barrington and I was born on the 26th of January 1990.
Okay, Grace, we'd like to examine your eyes today and test your vision. Is that all right?
Yeah, that's fine.
So those are the glasses that you normally use to look in the distance with.
Yeah.
If you could keep those on for me, please, and cover up your left eye. And then with your right eye, read down as far the chart as you can.
E H X U A H T Y O B U A X T H Y X. That's it.
Okay, and if you could cover up your other eye for me, please.
T V H X U H U Y.
That's great. Okay, now if you cover up your left eye again for me, please. Got some little holes here. You could hold those against your right eye. Look through the little holes and see how far down you can read.
H A Y O U X. And that's it.
So now I'm going to test your near vision. If you just read the smallest line that you can, if you can't read anything on that page, then we'll test with the other page. Great, so if you could cover up your left eye for me, please, and read the smallest line that you can do at arm's length with your right eye.
Sense of breaking new ground by actual experience is still more apparent in the art, and here it has wider scope and greater basis of reality.
That's great, thank you very much. If you could do the same with your other eye for me, please.
As we went along,
Okay, great, so I'm going to check your visual fields now. If you could take your glasses off for me, please. And if you could cover up your right eye for me, please. Have a look at my nose here. Is there any part of my face that's missing?
no,
And then cover up your left eye for me and have a look at my nose again. Is there any part of my face that's missing?
no,
Have a look at my eye there and say when you can see my fingers.
yeah,
Say if they disappear.
no,
Tell me when you can see my fingers.
yeah,
Say if they disappear.
no,
Okay. So when you can see my fingers.
Yeah.
Say if they disappear.
no,
Say when you can see my fingers.
Yeah.
Say if they disappear.
no.
Now I'm going to examine your pupil responses. So if you could fix on an object in the distance for me, please. I'm going to shine a bright light in your eyes. It's going to go from one eye to the other eye. Now I'm going to go from one eye to the other eye. I'm now going to test how your pupils respond to focusing close. So if you could have a look at the light switch there in the distance, and then have a look at my finger here. Okay, great, so I'm going to check your eye movements now. You could have a look at this red dot for me. Are you seeing one or two red dots?
One red dot.
Okay, if you could follow it with your eyes and keep your head still for me, please. And tell me if you get any double vision. Any double vision there at all?
No.
Okay, thank you. Okay, Grace, I'm going to have a closer look at your eyes now with this machine here. If you could have a look for me in the distance over there, perhaps at the light switch. I'm going to come closer and there's going to be a bright light. I'll pop a hand on your shoulder so that we don't bump into each other. Okay, and look at the light for me, please. Okay, that's the end of the examination. Do you have any questions before we finish?
No,
Okay, thank you very much.
thank you.
So I really like this exam, this demonstration, this video, because I like how when he's looking in the eye, they give you a visual of what he is actually looking at. The one thing I want to point out in terms of him doing the Snellen letter test, you know, his Snellen chart looks different than ours. Let me go back to that in our slides. But I just want to point out, so here's the Snellen chart. I want you to keep in mind when you use the Snellen chart or the illiterate E chart, which is for people who don't know how to read, you could just use the E one as opposed to all the different letters. You want to make sure the client is standing 20 feet from the chart. Most primary care offices, like in my daughter's pediatrician's office too, like they have the floor marked with tape just to make sure it's 20 feet away. You want to cover one of the client's eyes and have the client read the smallest line. You want to do the same with the alternate eye and then test with both eyes open. Okay, the first number indicates how far the client was standing from the eye chart. The second number indicates how far the person with normal sight could read the letters of a particular height. So for instance, a measurement of 20/40 means the client can read at 20 feet what a normally sighted person can read at 40 feet. Okay, so here would be 20/40 right here. So that person can read PECFD. And again, that means that the client can read at 20 feet what a normally sighted person can read at 40 feet. Always indicate if you're measuring them with or without glasses. Like sometimes you want to measure them with glasses to make sure their glasses actually are working or up to the right prescription. If the client is age 40 or older, you want to check near vision by having the client read at a distance of 14 inches, just like that guy showed you in the video with his little book. Okay, good. All right, so next is corneal abrasion and foreign body removal from the eye. This is something you probably would most likely see in an emergency department or primary care or urgent care office.
This is Dr. Brendan Cronin from the Queensland Eye Institute, demonstrating corneal foreign body removal, which is a common presentation to ophthalmologists. These 7 points are critical to follow to ensure you have a good, safe technique and a comfortable patient for this procedure. As you can see here, there's a peripheral corneal foreign body that's quite metallic in nature. I'm using the needle, keeping it parallel to the eye to easily remove that little foreign body there that had been in for a couple of days and so had rusted into the eye. A lot of these foreign bodies are sharp metal objects. It's important to have previously ruled out a penetrating injury in all of these patients. That would obviously be a significantly more invasive procedure to have that removed and will often require a vitrectomy. You can see with all of these procedures, I'm using a needle that's just kept parallel to the eye, with the patient fixating in the distance and the light is kept out of the pupil. It's important to caution all of these patients about the importance of safety eyewear to ensure they don't get a nastier injury next time. It's also important that the fornices are examined thoroughly and the upper lid is averted to ensure there's no hidden foreign body.
Good. And then next would be your eye irrigation. So this would probably be more likely something you would be doing as opposed to removing a foreign body from the eye. That more would be a specialist. Eye irrigations are pretty common. And it's usually done to rid the eye of irritants from chemical exposure. That's what gets in people's eyes. Obviously, precautions should be taken for patients when they're working with any kind of acid or alkali chemicals because they're super strong chemical irritants. Um, you know, Exposure to chemicals such as lye, lime, mortar, cement, plaster, liquid ammonia are highly damaging to the eye and they require immediate emergency care. That's considered what they call an ocular emergency. Um, so complicating factors that come with exposure to any of this stuff are corneal injuries, permanent loss of vision or temporary burns. You want to make sure that you really give the patient some consent and before you do any kind of procedures, as well as making sure you educate them on follow-up, the importance of follow-up appointments, and just taking safety precautions to prevent further injuries to the eye. All right, so here's a demonstration of how you would irrigate somebody's eye.
Irrigation of the eye is a common procedure performed after a presenting complaint of chemical or bodily fluid exposure to the eye. Chemical exposure is a very common occurrence in both the workplace and at home. Improper management can lead to permanent visual and ocular disability. Thus, appropriate and timely treatment is imperative. Both acidic and alkali compounds may severely damage the cornea or other structures of the eye. Acidic burns tend to be superficial and limited in damage, whereas alkali injuries are usually more severe and may penetrate the eye. If there is suspicion of an open globe injury, perform a fluorescein examination of the eye prior to irrigation. If perforation is confirmed or is unable to be reliably excluded, proceed with gentle irrigation and obtain immediate ophthalmological consultation. Place the patient supine on the stretcher. Hang the bags of saline irrigation fluid several feet above the patient's head. If available, a plastic drainage bin may be used to collect the irrigation fluid. Check the pH of the eye prior to irrigation by placing a piece of pH paper in the inferior fornix. Normal pH of the eye is 7.0. Next, place 2 drops of topical ocular anesthetic in the affected eye. Ask the patient to look upward and place the medication into the inferior fornix. Instruct the patient to keep his eye closed after the application in order to retain the medication. If there is suspicion of particulate matter in the eye, sweep it out with a moistened cotton-tipped applicator prior to irrigation. Both the inferior and superior fornices should be swept. Open the wheel clamp on the intravenous tubing and begin to irrigate the eye. Hold the tubing several centimeters above the eye. Direct the flow to all portions of the eye, including both the inferior and superior fornices and the cornea. The duration of irrigation will vary according to the clinical scenario and must continue until the pH is normalized. In many cases, 15 to 20 minutes of irrigation are required and several liters of saline is used. The patient may require additional topical anesthetic during the irrigation procedure. The patient presented in this video sustained a chemical splash to both eyes, so the irrigation process was repeated on the opposite eye. Remember the key steps to irrigation: assessment of pH prior to irrigation, application of topical anesthetic, removal of particulate matter with a cotton-tipped applicator, and copious irrigation with normal saline solution. The Morgan lens may be used in cases where prolonged irrigation is required. Attach the lens to the saline tubing, then open the wheel clamp so fluid flows through the device. Remember to apply a topical anesthetic to the eye prior to insertion of the lens. instruct the patient to look downwards and insert the lens under the upper eyelid. Next, ask the patient to look upward and insert the other half of the lens under the lower eyelid. Once the lens is fully inserted, increase the flow of saline through the tubing. Morgan lenses do not provide vigorous irrigation and may not thoroughly irrigate the fornices. They should thus be used only after primary irrigation with 1 liter of saline. Morgan lenses are useful in cases in which bilateral irrigation is required, as they allow a single clinician to irrigate both eyes simultaneously. After the irrigation is complete, evert the upper eyelid to ensure that there are no residual deposits in the superior conjunctiva. Apply gentle pressure to the superior part of the superior tarsus with a cotton-tipped applicator, then lift the upper eyelid margin upwards and backwards toward the patient's forehead. Hold the averted eyelid in place with the applicator and use a second applicator to remove any visualized foreign material. Resweep both the inferior and superior fornices to remove any residual particles that cannot be visualized. Check the pH of the eyes again after irrigation. If a neutral pH of 7.0 has not been achieved, continue the irrigation. Once the pH has normalized after irrigation, repeat the determination in 20 minutes to assess for any delayed changes. Perform a slit lamp examination of the eye to assess for corneal injury and for particles embedded in the conjunctiva. Additional aftercare instructions can be found in the written portion of this procedure.
Okay, so hopefully you won't ever have to do that because it looks a little scary, but that's how it's done if you do have that sort of emergent situation on your hands with your patients. So that's pretty much it. Just a quick review, just so we're very clear on eye ocular issues. Just remember vision testing. If you're testing for distance vision, you're using the Snellen chart, which measures central distance vision. If the person is illiterate, you're using the tumbling E chart, or the, you see it in your book, it looks just like all E's, just in different shapes, variations. If the patient wears glasses, you want to test the vision with the glasses in both eyes, the right eye, and then the left eye. Remember, both eyes is OU, right eye is OD, and the left eye would be referred to as OS. S is in Sam. Near vision, you want to check near vision. You just ask the patient to read small print. If you want to check peripheral vision, you're using the visual fields of confrontation exam, and you want to look for blind spots and peripheral visual field defects. To check for color blindness, you're looking using the Ishihara chart. And remember, in terms of your visual test results, you know the definition of a Snellen test result. You want to look at your top number, which is the distance in feet at which the patient stands from the Snellen or picture eye chart. Always 20 feet and never changes. The bottom number, or the denominator of your Snellen test results, would be the number of feet at which the patient can see compared with a person whose normal vision is 20/20 or less. The number changes. The bottom number is the one that changes. The 20 is always the top number. The bottom number changes based on the patient's vision. If a patient gets 20/60 on their Snellen test result, in this example, the patient can see at 20 feet what a person with normal vision can see at 60 feet. And keep in mind, legal blindness is defined as 20/200 or less. And just keep in mind, in terms of children, by the age of 6 years, visual acuity is usually 20/20 in both eyes. Use the Snellen chart with the child standing 20 feet apart, 20 feet away from the chart. If the child's vision is not at least 20/30 in either eye by age 6 years, we need to refer to an ophthalmologist. All right, so we're going to get into a little more detail about treatment planning in the following PowerPoint. I have two more PowerPoints I'm going to voice over for you. One is pretty quick. It's treatment planning. That just really just goes into more focus on the NP's role in treatment and diagnosing, which we covered in the Art of Treatment in Chapter 4. And then we're going to have one more presentation also just to review more ocular issues. It kind of goes, this particular PowerPoint goes more into the detailed depths of each particular ocular issue. So I'm not going to read it to you. I'm going to scroll through it because I just want to point out the things that are important to really pay attention to. All right, thanks guys.